Done. Good evening, everyone. I guess tonight we wanted to chat about, the final sort of webinar in the series on our lingua vertebral base narrow puppies. I guess previously we've discussed deciduous dentition, the interceptive sort of treatments that we do, and tonight we're sort of wanting to go through, I guess, our decision making and I guess how we talk to clients about the different treatment options when we've got a slightly older pup or other treatments have not really worked and we're in a position where we need to do something a little bit more definitive or involved. So we'll run through that. I used to introduce ourselves to those that haven't attended before and don't know us. My name's Dr. Bechtub. I have been working at Advanced Animal Dentistry since 2015 now. I am completed my residency, just waiting to finish one final exam once COVID settles down and I'm allowed to the US. Aaron can introduce himself.
My name's Dr. Aaron Forsay, and I have been one of the owners of Advanced Animal Dentistry for, I think I looked at it today, 16 years, coming up to 16 years. I like dentistry, I like talking, so it makes a good combo for tonight. And we've wanted to put on these webinars for everyone out there just to get some information out there, because what we've started with, I guess, first with these base narrow pups is something that we all see. So we just wanted to sort of get it down there and just let people know our approach towards it. And so tonight we're finishing off here, as Beck said, with just these more definitive treatments. Some of the animals that we may not have been able to catch and treat earlier. But as I like to remind all my clients with this problem is that ultimately we're always going to be able to make the animal comfortable. So it's not the end of the world. We can get them sorted out, and tonight we'll go through those major treatment routes in the around 8-month-old dog. So we've covered off the puppies, the very young puppies, the weeks-old puppies. We've looked at dogs at around that 5 months of age during the eruption of permanent teeth. Now the dogs that we're dealing with right now, we're dealing with them with their permanent dentition is now firmly set in place. So tonight, as before, we'll describe the problem, not in that much detail tonight. We've been through that over the last couple of webinars both times, so it's no different now.
No.
I think a big focus really will be the way that we discuss these issues with clients, to give them a real good understanding of what they're up against so they can make very informed decisions about treatment plans. We'll talk about those treatments, and we will touch on complications. That's a reality with I guess a lot of the things that we all do. No matter what discipline you're looking at, there are potential issues with these things. So let's quickly move on, and we'll talk about, just again briefly, this touch on the description of the issues that we're dealing with. So this time we're dealing with the as I mentioned, the permanent mandibular canines. They have erupted. Okay, they are full height now. Asterisk. Sometimes they're not. Sometimes these teeth, if they are traumatizing palate, will be retarded in their full eruption, and they may not really get to their full height until that downward pressure from the palate is relieved in some fashion. But generally, we're talking about fully erupted permanent dentition here. And with these base narrow or linguaverted mandibular canines, their position in these patients is causing trauma, and that trauma occurs with soft tissue. And I think we all recognize that pretty easily, and clients can picture that easily when they see inflamed, damaged mucosa of the palate or the diastemas. Sometimes what goes a little more unrecognized is that there is also hard tissue trauma going on. The bone, the underlying bone of the palate is being damaged and will be resorbing, and even the other teeth that these canines are in contact with, and will certainly be suffering attrition, which will ultimately cause quite a lot of problems as well.
Yeah, absolutely. And I guess that's something that trying to describe it to the owners in a way that they understand. So they sort of appreciate the problem and the need for intervention as well. So certainly the more significant ones, one of the worst complications we'll see if left untreated is development of oronasal fistulas. And that's becomes a big deal for them. One, because it's chronic discomfort to get to that point where they create the fistulas, but also if left again untreated, chronic rhinitis and nasal disease, but also then a much, much bigger surgery and procedure for the patient to go through with repair, and the risk of, complications associated with that as well. So trying to sort of not scare them, but give them, I guess, an idea of what potentially can go wrong if left untreated. Obviously, not all of these will progress to that. There's variations in terms of severity, but I guess many of them will, or they'll at least end up with significant sort of damage and disease around the upper canines, and will ultimately lose those if things are left untreated. So that's all stuff that we try and get across to the client.
And that can be difficult because this is certainly not a disease that generally has an acute relationship with the trauma. It's a medium to long-term problem that we see, which unfortunately then can lead to the clinical presentation being completely missed. I think that's actually one of the bigger problems with it. The patient themselves will, whilst they are suffering discomfort and trauma, because it's a chronic issue, they don't often show what's going on. So explaining that these things will happen in time, as much as it doesn't look like it right now, sometimes these devastating issues will occur, as I said, in the medium to long term. What's the shortest we've seen, Beck? I think oronasal fistulas in 9 months. Rare. I think for a long time I was always saying, it's not going to happen until 18 months to
No. Yeah, and that's more commonly what we see. But the youngest was a 9-month-old dog. Was pretty horrendous. Yeah.
So again, we won't dwell on this slide too much, just following on from the problems that we have here. Again, this is the mature version of what we've seen earlier on in our 12-week-old pup or our 5-month-old pup. This issue comes about through various means. It may be an individual tooth problem, so a class 1 malocclusion. Classically, class 2 malocclusion plays a large role, and probably would form the largest skeletal malocclusion that we see contribute. Yeah, so an overbite. Okay, coming in like that. But class 3 malocclusions also can put those teeth into a poor position. Class 3, where we have an underbite. And sometimes it's just the way they have things there, and the mandible may be too narrow. I've just had a little reminder as well, with Zoom and the way that we've got it set up in a webinar situation. There is a Q&A or question and answer panel where you can pop up, and it's certainly very, very welcome. We really encourage it. Welcome to throw up any questions. We both can see that, and we will answer any questions you have throughout the night as well.
Yeah, for sure. Anything else we need to talk about on that slide?
Not with that slide, I don't think. So those are often they're the basic issues with that. And then on the next slide, what we have, there are some other complicating factors that can make things, well, they don't make things better, but can make it worse. And we see issues with incisors, both in the maxilla and mandible, having an impact on the positioning of the mandibular canines and the maxillary canines themselves. We've got an example tonight where the maxillary canine and their position really had an impact and drove the mandibular canines to be in an incorrect position. A lot of that can be associated, and we talked about this in webinar number 2. A lot of that can be attributed to these persistent deciduous canines. They have a lot to answer for, those teeth.
They really do. So I guess we've already touched on this a little bit, but when we talk to the clients, when we're sort of discussing the actual problem, and I guess how we go about treatment, what we sort of want to get across to them is that it's the tips of the mandibular canines that are causing the trauma, and we basically need to get those teeth out of that position to alleviate the trauma itself. The way we can approach that is to either move the teeth out of that position into a non-traumatic or atraumatic position, or we remove them. In order to move the teeth, then that's going to involve orthodontics of some description. And again, depending on the specific malocclusion and position of the teeth, that can be relatively straightforward to quite complex. And in some cases, not practical at all, especially in a lot of these class 2 malocclusions or overbites. You'd basically need to be moving the jaw, not the tooth, to alleviate the trauma, which is all theoretically possible, but not something I would ever want to put one of my patients through. And the other options we've got are to actually remove the tips of the teeth out of that area. And that can be with physical removal of the tooth, i.e. extraction, or it can be with an endodontic procedure such as a height reduction, which is where we are essentially cutting the teeth into a position where they are shorter. And then we need to perform what's called a vital pulp therapy to actually cover over the exposed root canal and protect those teeth from essentially the outside world.
Yep. Yeah, and most people take that on board pretty easily. I don't think it's a hard concept. There's something causing trauma, get it out of there. And there's a couple of different broad methods that we use to achieve that.
Yeah, absolutely. So height reduction is something that we are performing pretty commonly at the moment with the seemingly influx of base narrow or linguaverted patients that we see. This is something that's going on in our practice multiple times a week at the moment. A height reduction essentially, I guess it leaves the patient fairly close to normal. Obviously, the canine teeth are not as functional as they used to be in terms of if they're in their normal position and normal height. But again, that's something that our patients tend to cope very well with because they don't need them for their natural function, which is to kill things. So we're essentially keeping structure of the jaw. So that's one big advantage of it. And that's, I guess, a complication of extraction that we are going to impact the structure somewhat. It is a very positive procedure for that, and that's, I guess, why it appeals to many of our clients. It does introduce an element of risk to the teeth in terms of we are interfering with the normal structure. We're entering the root canal by doing this. We're creating trauma by cutting the tooth, and all of these things can actually result in the tooth developing chronic inflammation and going on to actually die at some point. Thankfully, that's not very common, but it absolutely does occur. And again, if it does, the patients are pretty terrible at tapping their owners on the shoulder and saying, hey, something's gone on with this. So it is something that requires both short-term and long-term follow-up. And that's something that I guess from our perspective seems to be a little bit of a shock to a lot of the clients that are referred. And I think that it hasn't been, I guess, put out there very well to a lot of the vets that are referring these patients in. And that's probably, I guess, an unfortunate thing that it's not been communicated well. But this is a procedure that, whilst very successful, does involve essentially commitment for the rest of the patient's life. And that can be something, I guess, of a balking sort of point for a lot of owners.
I think on that point, Beck, I think that that's a limitation, I guess, in a referral situation. I rarely refer things anymore. But when I was in general practice, referring things doesn't mean you need to know all the ins and outs, and there's no possible way that all of these things can be put across. Like, we have the luxury of time to be able to sit down and explain these things at length, and I guess we get to do it a lot. So yeah, running a 15-minute consult where you've identified this issue and then giving a complete explanation, not expected. But I guess, again, with webinars like this, we hope to just inform you, because I think it is an important point to pass on. I would hate to think people just balk at that point and don't explore it, but they do need to have some idea that that may be occurring. So I said we'd definitely get this question.
We would. Yeah, absolutely.
Good question, Karen.
It is. It's, I guess, it has seemingly improved quite significantly in recent years. So in recent years, there's been a shift towards using newer materials as our actual pulp dressing. So the material we place directly over the exposed root canal. And our current success rate is somewhere in the vicinity of about 90%. At the moment, I guess that is short to medium term follow-up. We don't have years and years of follow-up on the ones that we're using these newer materials on, but there's even been a bit of a shift in human dentistry. I guess a vital pulpotomy, so they don't tend to do the crown amputation part, but if someone has broken a tooth or has a deep cavity with caries, and they actually expose the root canal while clearing that out, traditionally you would have had a root canal performed, and it is still considered in human medicine the treatment of choice. But there is a real shift in the thinking with these newer materials, where they're comparing success rates and finding that the materials used for vital pulp therapy actually have an excellent long-term success, even in sort of, you know, teeth where previously in people they would have done other procedures. So yeah, currently we sort of went through a period where the older materials, I wasn't particularly happy with it, and felt that, you know, our success rate wasn't as high as I would have liked. But with these new ones, yeah, we are seeming to get it up around 90%, which is really positive.
Yeah, really positive. I always, and I even say to my clients when I'm talking about this, I think it's an interesting point on human psychology. We used to really approach this, and certainly prior to Beck being on board, when I was using these older materials a lot all the time, the way that we would used to approach, you go, oh yeah, no, the success rate, above 80%. And people go, oh, wow, that's really great. 80%, wow, sure bet. But if you turn that around and say, hey, there's a 20% failure rate, I go, that's something I need to think about. And so we do that now. I think we both take that approach, don't we, Beck? So we would rather highlight that there is a failure rate. You don't be scared of it, but be aware of it.
Yeah.
Rather than, I think, just glossing over it by, oh yeah, 90% success. Oh, that's really great.
Yeah, and I guess that's the importance of the follow-up as well. So with the follow-up that we recommend, we're generally doing this procedure at 8 months of age. That seems to be our sweet spot. There's no harm in doing it when they're a bit older, but when they're younger, the tooth is much more, I guess, much less mature. And again, the success rate does seem to drop a little bit, but also we have, I guess, almost an eggshell of a crown, and a very, very big pulp chamber. So we end up with a lot of filling or restoration on the actual surface. And I think that in, you know, slightly younger dogs, that's more prone to being damaged and lost as well, which would contribute to a higher failure rate. So it does make the procedure technically less difficult, doing it at around that 8 months of age, and we seem to have a better success rate. Our follow-up that we recommend is to see them back 3 to 4 months after the procedure for follow-up dental X-rays. I guess at that point, what we're actually looking for is continued maturation of the tooth, and that is fairly obvious in such a young patient, because that from that period of sort of when the tooth erupts to about 12, 18 months of age, there is significant and rapid change, I guess, in the maturity of the tooth that's fairly, I guess, predictable and easy to track. So we'll actually see thickening up of the dentine, narrowing of the pulp chamber. And what we also want to see is a new bridge I guess tooth material underneath the fillings that we've placed, and they're the signs we're looking for initial sort of success. So the tooth actually survived the procedure, it's behaving as we expect, and then our recommendation is every 12 to 18 months these patients have dental X-rays, generally back with I guess you guys, if you have the capacity to do the dental X-rays. We think that that's, I guess, the ideal scenario, and often will be combined with the scale and polish, which is, I guess, another factor for these guys as well, that we also mention. A lot of these patients with these underlying malocclusions, especially the overbites, they don't possess a very good self-cleaning mechanism, so they are often a little bit more prone to periodontal disease. So it's very likely that the vast majority of these patients will be requiring a scale and polish every 12 to 18 months. So that's another way of, I guess, reassuring owners that yes, it needs follow-up, but will most likely be something that you'll be having to commit to just for the routine dental care and oral health of these patients.
Yeah. So rather than being a standalone procedure with us, it can be basically a tack on with, as Beck said, as hopefully standard periodontal therapy as the dog ages.
Yeah, sure.
Actually, I think it's an interesting point you made before, Beck, and I didn't say anything. I hadn't thought of it till tonight, actually, till you mentioned it. In all the discussions we ever have about this, it's interesting. I think you're dead right in regards to when we used to perform it on younger dogs. When I first started with Dr. Gary Wilson, we were doing it as early as 6.5 or 7 months of age. And we had a failure rate was noticeable. I think you're correct insofar as loss of restoration material was something that we saw. And yet, even in that, like the animal I saw today when I was talking about it, as I said to him, I so rarely see loss of fillings these days.
Not in the newer ones, yeah. Ones
and again,
I still see it in patients, 6, 7 years on with the older materials we were using. But the better.
Yeah, material technology is better, and certainly age and more appropriate.
For sure. There's a question from Erica as well about what analgesia and other treatments we recommend be given in the period prior to referral. It's a really tough.
I find it really hard, and I to some extent sort of slump my shoulders when I talk to clients about this. When we've seen them at 5 and 6 months and go, okay, we've got no options right now to alleviate. We are going to see these dogs come through at 8 months of age. Your pup now has 2 to 3 months ahead of it. And I slump my shoulders and say, we're going to politely ask that the dog put up with it. It's tough. I don't personally believe, I think chronic use of non-steroidals for that period is not appropriate in that age. How about you, Becky?
Yeah, no, I agree. And I also feel that it's not a problem that's causing constant discomfort. And that's where it's like, is an analgesia or analgesic that you give actually going to make a significant difference for this patient? I'm not convinced it is, because if they've got their mouth open or marginally open, it's probably not particularly painful for them. If they close and that, I guess those teeth touch that tissue, then that might provide, a short period of discomfort. It might be, that hurt. Or if they slam their mouth shut and play and the likes of that, or if with excitement, then yes, it's going to hurt. But that will probably pass. So I feel like it's chronic intermittent discomfort. And it definitely is impactful on their quality of life. But is it something that, persistent use of analgesia and the likes of medications really helps with? I'm just not sure.
Yeah, I agree. And I think because the discomfort points, I think it's a mix of chronic and acute, but it's more the acute ones. and it will break through anything we're using anyway.
Yeah.
So yeah, I think it sucks a bit. Yeah,
It's a really difficult
bit.
one, yeah. And I think, yeah, for these guys, unfortunately, the ones that get to this point before treatment, they go through a period where it's not particularly fun for them.
Yeah.
We'd recommend that owners, if they want to have the animals want to have a toy in their mouth, a lot of these guys really like to have something that acts as a bit of a spacer. We've had dogs stuff I guess blankets in their mouth to sleep, and that was their way of coping with it. We recommend generally not playing games with them where they're going to be sort of, going to grab and slam their mouth shut. So sort of just trying to modify their behaviors as much as you can with a young bouncy puppy is what we recommend.
And the big but to it is that don't just sit there and go, oh, we have to wait until 8 months. Plans can change if we are receiving that feedback from the patient or the client, and together we come to this idea that this dog is not coping. Okay, we might need to go to a plan B. We might look at, and we're going to be talking about next, we might need to look at extractions.
We have in the past as well done, I guess, a odontoplasty before, where we have reshaped and flattened the tips of the canines to just try and alleviate a little bit of the trauma. Whether or not that makes a significant difference for the patient, I don't know. It's really hard. And
I've gone off that.
We have this conversation every day. Without patient feedback, it's so difficult. We're making all these presumptions on what we feel and we think. And I guess there's subtle things they tell us about their behavior.
But we could be right and wrong on both ends of that spectrum. It may not be as bad as we are maybe making out. It could be way worse. The lack of patient feedback is a concern.
Absolutely. So I guess with height reduction, when I'm talking to people about it, the big positives are that it does maintain structure, it maintains function and keeps the patient in the situation where we really don't have the option to move the teeth. It keeps them as close to normal or their normal as possible. So that's a real positive, and that's a real driver for some people. The negatives for it are that I guess we do have the risk of failure. It is low, but we do see a percentage of patients that come back and they either need further treatment, and for some of them that can be going on to have a full root canal performed, or our fallback always can be removal of the tooth. And it does require, some commitment to long-term follow-up. And again, I think most people are pretty understanding that at the moment. What do you reckon? Do you reckon we're getting probably 50-50 with height reduction versus extractions, or a few more going with height reductions? It's sort of
I think
a little bit.
Yeah, a few more go with height reduction. I think ultimately a lot of clients, in conjunction with you guys in discussion, have come to that decision that is the way they're going anyway. It can come as a surprise to some people. We should actually move on to extractions, because I guess this sort of ties into it. Some of them become a bit surprised about, we need to show these pictures. Some of them are surprised that actually extraction is even an option. But yeah, I think my end,
We've
doing more.
changed our, I guess, the way we discuss extractions with people, and we'll go over that with you.
We'll touch on it.
Yeah. Just so I guess this gives, if anyone's unfamiliar with how these teeth look after a height reduction, essentially you can see that we basically go through and cut the tooth, generally close to the level or the height of the mandibular incisors. So it ends up essentially like the patient has a flat sort of plate of teeth at the front of the mouth, similar to us. So nothing's really taller than anything else. So when they do close, hopefully there's no contact, but if there is, everything sort of just comes in contact together. So that does tend to alleviate any trauma that they experience.
Versus the force. So we're not just concentrating on that one point.
Yeah. You can see, I guess, the restoration sitting just sort of here. They're
slightly off-white.
Slightly off-white. It's really hard to get a perfect color match for a dog's tooth. And I guess if you ever see them back for a recheck, things to look for, it's quite normal for the dentine around the actual filling to get a little bit of stain uptake over time. So a little bit of yellowing or browning of that isn't necessarily a problem. What we want to see though is if you run your dental explorer over the tooth and the restoration, that it feels smooth and it's not catching, and that you can't see sort of a crack around the edge of the filling. And again, that the filling itself is there. We do use a layering technique and multiple layers of fillings within the actual cavity recreate. So if they chip or damage, hopefully it's just the surface layer and everything else is intact. But if any of those things aren't quite right, it really should sort of trigger, I guess, a review and potentially repair of that as well. So they're things to sort of look at if you are, I guess, confronted or find yourself in a situation where you're having to reassess one of these guys.
Confronted.
Well, I don't know. Might feel that way.
Yeah.
This is a series of X-rays, and again, if you are put in the situation where you're, I guess, the clinician that's taking follow-up X-rays down the track of a patient after they've had a height reduction performed, these are the views that we find to be the most useful. So we get basically a straight on, I guess, ventrodorsal sort of view of the actual mandibular canine teeth. And the picture on the left here, that is actually the pre-op picture or X-ray of this patient done at the 8 months of age mark. And you can appreciate that we do just have a complete apex that's formed on these teeth, but a really big, wide pulp chamber here. And this is the, in the middle picture, this is 3 months later. Fairly similar angulation of the actual image. It's not perfect, but you can see we've got an absolute definite, an absolute definite narrowing here of the actual pulp chamber compared to the picture on the left. So that's something that we're tracking. The other thing we're looking at again is the actual apex of the tooth. We can see that we've got thickening of the dentine in that area, and we also have a well-defined periodontal ligament. So that black line around the actual outside of the root is really tightly conforming to that tooth shape. We don't have a big black lucency that could indicate abscessation and infection. So on that view there, the critical things that we're looking at over time. On the pictures on the right, the top view is immediately post-operatively, and you can just make out the layering of the materials here. This bit here is the actual key to it all. That's the base layer. It forms a good seal to the tooth itself, but it also is aimed at sort of, I guess, inducing that calcification in the tissue beneath it. The second layer, you can just make out here and here. And then we have that top layer here. So there's 3 layers of filling material used in these, I guess, cases that we're doing typically. The picture below on the bottom right hand of the screen, what you can see here, this here is that layer of calcification, or the dentinal bridge that's actually formed beneath the actual restoration that we've placed. It's not a perfect barrier to the outside world in itself, but it adds an extra layer of protection. And it's also something that if we see that at that 3-month check, we sort of go, yeah, okay, things are doing exactly what they should. And that immediately makes us feel much, much better about things. The other thing that's quite obvious is, again, the width of that pulp chamber. So you can see a fairly significant narrowing just in that 3-month period. And that will continue to narrow pretty rapidly over the first 1 to 2 years of life, and then will slow down and occur at a much slower rate. So they're the angles that we think give us the best idea of what's going on and the basic things that we're looking at when looking at success with these or failure.
Yep. Absolutely. Yeah. So I've always still find it amazing how quickly teeth mature. And all from the outside, they just look the same. They just get dirtier.
Yeah. So moving on to extractions, this is something that I think personally I've changed my approach and tune to quite significantly over the last few years. I was, I guess, always of the opinion and had been always taught that you wanted to do everything you could to avoid extraction of the mandibular canine. And I do still believe that to a degree, but I don't think we need to be as fearful of it as many of us are and what we've sort of been taught to be. For me, when I'm talking to clients about this, I tend to sort of lay the options out without putting any real emphasis on what my preference would be personally. Because I guess what we've got to remember is any of these options we're going to discuss with you tonight sorts the problem out for the patient. The only thing that's the wrong thing is to not do anything. Whilst I might have a preference for one procedure over the other, any of these sort it out for them. So with extraction, it's definitely not a straightforward procedure, especially if you've got a slightly more mature animal. As they get older, it certainly becomes more challenging to remove these teeth. It can and does lead to some structural changes in the jaw. That said, this is where I think I've changed my tune a lot over the last little while, is that I don't think it's as significant as we have been led to believe. These guys, if we are removing teeth, and we are doing this again on a really regular basis, so we see them, you know, for their follow-up and the likes of that, and they do very, very well in the vast majority of cases. We don't tend to see that many of them prolapse or stick out their tongue all the time. The big difference is the old dogs, the Chihuahuas, the Maltese, we've all seen them. You've taken all their teeth out, they walk out and their tongue's flapping in the breeze and they look ridiculous. The reason, or one of the big contributors to that, is the fact they've already lost all the bony support around those teeth. We're taking those teeth out because there is no bone left. With these guys, we're removing teeth, but we're not really interfering with the bone very minimally. If we're able to leave the mandibular incisors, again, they're something that I guess triggers the bone to continually sort of rebuild and remodel. So we don't experience as much bone resorption because we still do have dental structures. We have younger patients that are using their mouths and the likes of that. So yes, there's change. Typically, it's probably a little bit of just narrowing where we've removed those teeth. And if, again, we're leaving those mandibular incisors, I think it's even less significant an impact for these guys. So I definitely talk about it. I tell owners that their dog could be that dog that walks out with their tongue hanging out. But in our experience, in these particular cases in young dogs, we don't typically see them holding their tongues out all the time. If they pant, they'll absolutely probably throw it to the side more. If they're sleepy and they're a bit of a short-nosed brachycephalic thing, they'll probably poke their tongue out a little bit. Most owners find that cute. But yeah, they don't tend to sort of, you know, walk around with their tongue flopping out all of the time. So that's one thing that we do try and, I guess, educate people on, but also not scare them and overemphasize it.
Yeah, I agree, Beck. I think there certainly has been, well, at least between you and I, there's been a great shift in the way that we approach that with clients. And I think it's always an excellent example of as much as we, and I know they don't, but we can make clients do anything.
Yeah.
And it is by the way that we discuss things. And I think certainly in retrospect, looking at the way that we used to approach this, and when we discussed it with clients, I did it. We used to put we put a bit more of a negative spin on it, and I think clients we would. I don't think we ever outright said this is the bad thing for your dog. but I think people came away with that oh, they didn't say it, but they were saying it, that it's not the right thing to do.
Yeah.
And I think that it may have been unfair, in maybe some animals were not treated well, because people didn't or couldn't go down that road because they thought it was the wrong thing, but couldn't go down maybe a high reduction road.
Absolutely. And that's the thing that I think we've come to the realization of as well. What works for one client and one patient won't work for the next.
Yeah.
So whilst I do have a preference for doing a height reduction, that may be what I would do on my own animal, it may be not what the person sitting across from me in the room would want to do. And again, we try to sort of, emphasize the negatives, and that's the change in structure. We're not, we are impacting these guys, but they will be okay, and they will function, and they will live a healthy, happy, fulfilled life in a domestic environment. The big positive for a lot of people is that once it's done and these guys have healed, there's no ongoing for them. The one thing that we do like to check in on a couple of weeks after extraction of these, especially in the patients that have class 2 malocclusions, so the overbites, they're the ones this can be a bit of an issue in. The incisors, I guess by removing the mandibular canines, you can change the contact points a little bit within the mouth. So if things can close a little bit further than they were before, on the odd occasion, and it's not particularly common, we do then see the incisors start to impact the roof of the mouth. So again, occasionally, you might get away with just doing what's called odontoplasty, where we can shave down and reshape those teeth. But if you then have to go on and remove those teeth as well, then those cosmetic changes are going to be more significant for the patient than if those teeth could be left. Is that did I skip a slide?
Yeah. No, I think that's the correct slide. So, so what we wanted to show here is that these are technically strongly similar to what we do with more with older canines, but the little trick to these guys is that they're not mature when we're taking them out, and you can see particularly on that radiograph there that those two canines do not have an apex formed yet. It's completely open. There's no root tip on it. And in this right-hand image, this is an extracted tooth at probably about, that would be like 5.5, 6 months of age.
Yeah, even 6.5, some of these.
Yeah, some of them. And that big slug that's next to it, that's the pulp. And they're gigantic in these developing teeth. And it is a little bit hard to see in the blood in the periodontal ligament there, but there's a crack running down that root wall. Yeah, that's exactly where it is, Beck. That root wall there. And that's because an elevator's gone through that.
Yeah.
Okay, they fracture. And I take delight in when I extract teeth like this. If I have a nurse that's never seen one of these before, I'll grab the tooth and you'll squeeze it, and you can actually squeeze the root and it deforms. That's how thin these things are.
If you hold them up to the light, they are literally eggshell thin. So,
so it takes a slightly different approach. It's we often obviously attribute mandibular canines to real grunt work extractions, but you can't go down that track with these guys. They do require more finesse. To offset that, where, well, how we get these big teeth out with finesse and not with grunt work, they aren't usually as attached as firmly as maybe a 7-year-old cattle dog's mandibular canine.
Yeah, and I guess to that effect as well, we always mention it, but for me, I just guess the possibility of causing a jaw fracture when removing these is very, very low. I think you'd be really doing, something would really go quite wrong for that to be a real possibility. The reason being, they do have quite, I guess, a wide periodontal ligament around them. There's no ankylosis. You're going to break the tooth before you're going to break the jaw in most cases. So for these guys, again, we always mention it, but I think it's a very outside possibility. And we actually, like Aaron and I, will approach these and not actually remove any bone at all if we can possibly help it. And again, it's that whole minimizing the impact on jaw structure. So unlike a mature tooth where you might have to remove that buccal bone plate to actually release attachment and actually facilitate you getting that tooth out without breaking the jaw. In most cases, we can get these out without really doing surgery at all. Obviously, we're closing them over, but we're leaving them essentially with all of that bone that they started with. So I think that also has a positive impact on in terms of sort of reduced change in structure for them.
Yeah. A question here from Cara. In regards, assuming the low risk in regards to jaw fracture, I assume that's what you mean, Cara, with canines. Yeah, absolutely. More mature, the better they go. But cats are tricky and cats are small and they have their own difficulties. I was trying to beat Beck the other day with my numbers. I'm better at this, I'm better at that. For me, I have fractured a dog's jaw during a mandibular extraction, but it was not anything like what we're talking about tonight. This was an older dog with severe periodontal disease. And similarly in cats, at this stage, I'm up to 2 over 16 years. And again, it's different situations. These guys, there's real degradation in the bone structure. So I don't think that these are comparable. And another question here from Jason, I'll just quickly read. We did discuss this the other day in preparation for tonight's webinar in regards to use of vet time. For me, if you've heard us talk about vet time before, we have used one, but we do not have one in our practice. This is possibly one of the I can't.
Don't say only.
Yeah, I was going to say only. Yeah, this is probably a good use of it. I think the mandibular canine extractions with a vet time is a real probably highlight for that instrument. But in this particular instance, we're always careful, of course, but you do want to be careful because I've not done it, so take that for what it is. I would have some concern over, again, the fragility of the root wall.
I would wonder if you could actually penetrate the root wall with the vet.
I think it's possible.
It is more bone-like than tooth-like at this stage in terms of, it is softer.
But I guess, look, the way that the vet time works, it generally will run within that periodontal ligament space. We've both experienced that sometimes it doesn't, but I think that is rare. I think that good point.
And I've fractured these on many occasions. Often you'll actually split the tooth, so you'll get 80% of it out and you'll leave sort of, a wedge-like fragment of it. They're actually relatively easy to go in and then remove those because, again, you've got that periodontal ligament that is quite wide. So essentially, you sort of, hold your tooth and you see, okay, it's the buccal wall that this bit's attached to. So I use a luxator. So you slide your luxator down. You can generally feel where it is. You can get behind it between the alveolar bone and the tooth. So just slide along the periodontal ligament, pop it off and pull it out. It's generally fairly straightforward to deal with that. Again, much less difficult than going in and removing sort of, the apical third of a canine that you've fractured. And again, you can generally sort of slide into that area and do it without having to take more bone away and get more exposure. So they're just different. They're something that it takes a while to develop a technique and a finesse for. But once you do, I think, they go pretty well.
And I think that speaks to Mike's question here in regards to use of a hand periotome during the process, I guess, and you mentioned it, I guess, Beck, periotome or luxate, I think that they're both achieving the same ends. This is an extraction where I think both of us, luxation is the primary technique we're using here. And in fact, exactly what we showed here before, this crack down the root where an elevator's gone in there, that is because we've been trying to use elevation techniques where we rotate and try and force the tooth across to a side or another, versus a peritome or luxation technique where we're actually directly incising and breaking down the periodontal ligament.
Yeah, and I think that is honestly the approach. I'll use my luxator basically almost the entire circumference of that tooth to loosen it, and I won't really attempt to actually extract it with my forceps until I've got a lot of movement and I can feel that, I've released the attachment all the way around. Once I'm happy that I've done that, it will generally, come out with relative ease, and it's much less likely to fracture or leave that fragment behind. Danielle, I like a 3mm one for these, even the really big ones, because I find it's that balance between how fine the actual tip is and sort of the width of it. And I'll pretty much use that size in all of them, anything from like a little chihuahua up to a pretty big one for this particular procedure, again, because I'm not really needing the width of the instrument, because we're not really doing that elevation where you're turning the instrument and essentially trying to stretch and break the periodontal ligament fibers that way. You genuinely are trying to cut them.
Yeah, absolutely. And I guess overall as well, and hopefully you've taken this on board already. So whilst it is a slightly different technique, this absolutely is a way that these can be approached in practice. I think that's the great thing about it. Like, I wouldn't expect everyone to be on board and start doing height reductions, but for those clients where that is not, they don't even come and have a consult because it's just out of the realm of reality. You can help these dogs with an extraction, and it's great because these dogs are going to be better.
They're going to be okay.
Yeah, they're going to be okay. So I think, and I say to clients, I'm at pains for you the take home message is that extractions are not bad for your dog. If there's one thing you take away from tonight, please take away that. The extractions are not, I think, the big boogeyman that we used to make out they were.
Yeah.
Okay, so the really fun bit. So orthodontics. So we've just talked about that the problem is these permanent mandibular canines, the tips of them are causing trauma. So we need to either remove them, which we can either extract as a whole tooth or specifically as a high reduction, or move them. So we can move that tip away from that contact point and into a more correct position. Sometimes we don't move it into the anatomically correct position, but as long as we've moved into a position where it's not traumatic anymore, then we've achieved our aim in giving relief for these patients. Orthodontics is fun. It always opens people's eyes when we talk about orthodontics. They go, braces for dogs. We don't particularly use braces per se. But yeah, orthodontics, it's pretty cool. It is fun. But I think there are issues with it. It's not for every case at all. And there's multiple reasons for that. It's not just the anatomical presentation, and how in saying that's the big one. There's a lot of these cases. There's just no way in the world that we're practically going to orthodontically move these teeth into an atraumatic position. So that would be the number one stumbling block for case selection. But also the clients must be aware of, and these do take some time to really explain and outline what's ahead of them. They need to be accepting of risk. The biggest risk that it actually won't work. So it may be a big financial risk for them if they put a lot of money into all this and time and effort, and then it doesn't work. And that can certainly be disheartening. There has to be an acceptance that it's a multiple interventions. This is not, again, it's nothing like something like an extraction where once it's been performed, apart from a quick checkup a couple of weeks later, for the majority of cases, that's it. This is you're going to get sick of this face, because you're going to be seeing us quite a lot as we work our way through from beginning to end with the patient. And the patients, we'd never actually get their direct feedback, but I would love them to accept that what they're about to go through is going to take a while, and it's going to take some cooperation.
It's going to take some changes in their behavior for that period.
It is. I think this, I guess, out of all of the interventions that we do, has the biggest direct effect on our patient behavior and places some limitations on them. If you can imagine, and we'll obviously talk about it in more detail, if you can imagine animals that have appliances, so they have material added to teeth, or they have wires or bands and things like that in their mouth, no one's explained what's going on. No one's told them, hey, please leave this alone. It'll in the end, it'll be okay for you. They don't know that. In saying that, most of our patients have been pretty good.
They generally do accept it very well. Yeah,
they're pretty tolerant.
There's certain ones that I honestly just wouldn't even consider it in, like some of those crazy staffies and stuff that, you can barely even look in their mouth in the consult, and they're picking everything up and biting everything and doing it. It's like, they're
not going to be a great choice.
No.
So orthodontics, what we're looking at doing is we're moving the tooth into a more correct atraumatic position. Now, sometimes it can be more complicated than just moving a single tooth. As we said initially, when we're describing the problems, some complicating factors, it may be that there's actually nowhere for the tooth to go. There may be no space for the tooth to move into. So sometimes orthodontics becomes, again, it is multi-interventional, because we actually have to maybe create a bit of a space for the tooth and then move it into it. As compared to the human situation, we do our orthodontics movements in a very, very short time. There's none of this
crude movements in comparison.
Absolutely. We don't, and whilst we may think that we have some finesse in extractions, we're pretty gross in orthodontics, to be fair. In saying that, we generally, if we go down that road, I think we generally get good success. We're pretty picky into what cases will go down these roads. It's so much so that it is something that we actually rarely perform.
Yeah. We are doing it a little bit more than we were, I think, in part because of the number of cases that we do see. And they're not all your classic class 2s or overbites anymore, with the multitude of labradoodles and other sorts of breeds that are purely linguaverted or base narrow. We do have an opportunity for orthodontic movement of teeth, because it is a little bit more practical to do it when it's just a single movement and a single step. It's still, a couple of anesthetics to get things done, but we are being presented, I think, with more cases that are candidates for it these days than in previous
more opportunities for sure. It's not an issue. It's part of orthodontics. And if any of you have children or have been through it yourself, there's two basic portions to an orthodontic movement. The first portion where the tooth is moved, and then there's a whole portion of retention where we need to convince the tooth that it needs to stay there. We don't approach that in the same manner as it is in humans. We are relying, because of the shape of the teeth, we're relying on self-retention. And again, thinking back to what we're doing here, we are talking about mandibular canines. If we can get that tooth back, I can't do this now. If we get this tooth back here in the diastema, it's stuck there. Okay. Now, one of the problems that comes about, and hopefully we can usually predict, but sometimes not. If we have the tooth is too short, it won't stay in that diastema. So we can move the tooth, and it's not high enough to make contact with the diastema, and it can actually move straight back.
Yeah. So yeah, we've got to look at retention options, because getting a dog to wear a retainer or something long term to hold that tooth in its new position for long enough for it to actually set and stay there is quite impractical.
Would you take it out of doggy daycare? Where is it?
So yeah, when we are moving these, we do need them to get into a position where they will catch in that new position and hold. So it's definitely something that comes into consideration in terms of whether or not it's a good candidate or not. If they're close but not quite there, and again with the right patient, you can build the height of the tooth up marginally with composite materials, and that will generally sort of hold it and keep it in position. And if a couple of years down the line it chips it or cracks it, then it's not a big deal in that you can reshape that and it will then at that point stay in that position. But again, if you've got the patient that loves to catch balls and is really hard on its mouth, then those materials may not be in position for long enough.
Yeah. So we're trying to move teeth, and there's multiple ways we don't have thousands of ways to do it, but we have a few different ways to do that. And veterinary dentists around the world are trying to adapt and utilize techniques in humans all the time. So something for me that's been new over the last, well, hang on, I've skipped ahead a second. We just talked about all the bad things with orthodontics. The good things, it's brilliant. When it works,
it's done. Yeah, they basically leave. They don't have long-term follow-up.
No follow-up.
And things are as normal as they can possibly be for them.
Yeah,
so you've retained all of the function because we haven't altered the shape or height of these teeth. We've hopefully moved them into a normal or close to normal position. So we have patients that walk out with a normal or close to normal mouth with no long-term sort of ongoing care. So it is a really good option for very particular patients.
Yeah. So, and I say to clients, if I could, I would absolutely prefer to be performing an orthodontic movement with your patient, with your pet, but it is so limited to a select few that can have it done. Mm-hmm. So here we have Miss X, who we've actually seen. We've seen her.
It's Poppy.
It's her name's Poppy. Yeah, we've actually put her name up before. This is Poppy. So we've seen Poppy over the last couple of webinars. Check out webinar 1 and 2, where you'll come across Poppy and we talk about her. And she has actually gone right through a lot of the things we've discussed, and recently has just finished a course of orthodontics. So we'll talk about, there's going to be a few slides about Poppy, just giving an example. So this is, I guess, a series showing, this is her initially, obviously as a 6-month-old dog, she's had these persistent deciduous canine teeth. You can see that very closed diastema. Okay, so between the 203, 204 is a tight little gap. There's no way the 304 is able to present itself labially through that spot. Removal of the deciduous tooth gave us a little bit more width there. There's been some movement. Did she have ball therapy?
She did, and she was really good at it, but it just didn't quite get her there.
She can't squeak out there. There's just not enough space. So this talks to the point, we have to have somewhere for the tooth to go to. So whilst we look on the right-hand side, the dog's looking pretty good. We didn't actually get an image of it, but there are some red marks there, and it's not the end of the world. She's not the worst. She's not going to get an oronasal fistula.
And honestly, if treatment ended at that point, I wouldn't have lost sleep over that.
Yeah, it's not a disaster at all, for sure. Yeah.
But she had that just wanted things to be as good as they could possibly be, and was really dedicated and wanted to go the full distance.
So Poppy fulfilled all the criteria we needed to be able to move forward with more advanced orthodontic treatment. And here she is. So we weren't quite there. So what we needed to do, we needed a space for the mandibular 04s to move into. So to do that, we need to have some distal movement, bodily movement of the upper 04s. They're big teeth. you know how big they are. They're tough to get out. So they don't like to move, and they do need a fair bit of persuasion. So what we've attached here, she has what we call a masal chain. This is an orthodontic elastic that has a predictable force of contraction. And it's been attached between the canines which we want to move, and it's locked into a base of the upper premolar 4 and the molar 1. Yep. Now, that anchoring point needs to be firm, because what happens when we are using the masal chain here, it doesn't know what direction to pull in. It's just bringing those 2 points together. So I guess we can't go through everything yet, but here's a complication that may arise. You can actually move the premolar 4. So the canine stays in place. You go, yes, we've had some movement, but it's been of the wrong tooth. That's a difficult discussion. But in saying that, it's a discussion of the potential has been had. This is why it's a complicated thing to talk about. We've attached 2 big teeth together. You can see there's a wire that's attached to both the molar 1 and the premolar 4. So hopefully that's a much more difficult set of teeth to move versus the canine.
So we've essentially got the surface area of 6 roots because both of those are 3-rooted teeth, and the surface area of those roots is greater than the canine, which is our target tooth that we're trying to move. So the aim is that we've created an anchoring unit that's going to stay solid and steady and allow the actual movement of the canine.
Yeah. So they were placed a little while ago, weren't they, Beck? We put them on.
Yeah, they were a couple of months now.
Yeah. And things went well. So we have these patients will visit us once a week. It's to check on how things are, but also for adjustment. The masal chain, as things are moving, it will need to be retightened. It also loses a little bit of elasticity, so we need to tighten it up as well, so we have a continuous force.
Yeah. I think these fish, Poppy, were on for about 4 weeks, which is fairly average. We try and limit, I guess, each specific treatment to a 4 or 6 week period. What we find is that the patients just don't tolerate it for longer than that. So this is what we've achieved 4 weeks after, I guess, placement of these masal chains. You can see that she now has an appropriate width to the actual diastema there. When she was closing, the lower canines were still somewhat linguaverted. It's hard to fully appreciate it on these ones. The left was definitely worse than the right, and they were still sort of impacting the soft tissue. So we'd always planned for her to do a multi-step staged treatment. The first step was to create the space for the lower canine to move into, because her issue was that narrowed maxillary diastema there. So we've definitely achieved that. So she underwent yet another procedure, an anesthetic, had the masal chain and the wires removed, and we placed our next device, which is, in her case, we actually chose to do crown extensions. I chose to do this again in this particular case, and it will vary between individuals because we'd actually partly overcorrected the upper canine teeth. I'd actually created a slightly wider diastema than I really wanted. So by doing this, because I'm not specifically retaining or placing a retainer on the maxillary canine teeth, it gives them a slight opportunity to actually drift back into the position that I want them to stay in. They won't overdrift because of the width of this extension that we've placed on. I basically made that the width that I wanted the diastema to end up being. And these are, I guess this is a photo 4 weeks after these extensions were placed. And what you can see is the tips of these, quite labily tipped or diverted, and we've actually, by placing these when they first were put on, essentially the extensions, we're making the teeth a little bit longer. So we're actually widening the space between the tips of those extensions compared to what the natural width between the two teeth is. So when she closes, the tips are engaging within the actual maxillary diastema. She can't fully close a mouth initially, but every time she does, she's putting and transferring a tipping force onto the teeth. So they basically, over a period of weeks, will tip out into a more natural, or I guess, labally sort of positioned.
So if we look back at webinar 2, when we're talking about interventions like a gingival wedge or ball therapy, this is an extension of that, and it is the same force, but we can be much more aggressive because we get to really control where the points of force are applied. And as Beck said, Poppy had a marvelous response to this treatment. She really did get some really nice labally diverting canine teeth. So I think the next slide we get to see once it's all cleaned up. And we can see the tips of those canines really sitting nicely just away from mucosa. Still there is still some nice spacing, so the diastema is open. The canines, it is a little bit on the right there, but the mandibular canines are not in contact with those the third incisor and canine complex in the maxilla, and we're seeing the tips again just clear of the soft tissue, which is really lovely.
Yeah, absolutely. So I guess to give you a before and after for an idea of what we can achieve. The picture on the left is where we started with her at 6 months of age. She's now 9 months of age. And we've ended up with what would be, considered a pretty normal occlusion. I think this was achievable in her because she was purely base narrow. She wasn't a class 2 or a class 3 malocclusion. Her real primary issue was the persistence of that deciduous tooth. If she hadn't have retained that and it had actually been removed a couple of weeks earlier than it was, things probably would have self-corrected. And that's going back to the last webinar, the importance of timing. If we'd only seen her a couple of weeks earlier, things probably would have been fine of their own accord. But it just shows that we can, with the right patient, right client, achieve pretty significant sort of changes and really good outcomes. But it's a pretty involved process. I think in total for the orthodontic side of things and the other, like the extraction of this, she's had 4 anesthetics and 4 procedures over a period of months. So it's not a small commitment from people when, really trying to achieve these things.
And again, looking back on that, absolutely an option for some, but it's complex. Extractions are not the wrong choice for some of these. It would have helped her as well. This was actually, I like this one because it was the first time we really, not really, it was the first time we ever worked with crown extensions. And to our knowledge, I guess it probably, who knows? To our knowledge, first time it's been performed on a cat. People that we've spoken to have not ever come across that before or done it themselves. So this kitty cat here, I suppose we shouldn't divulge the patient details, but I can't remember her name, but she has a big diastema. So there's plenty of space there for those mandibular canines
She was actually a minor class 2. She wasn't really significant, but she was a class 2.
But look, kitty cats, we all know how sharp their little bits are. So nasty, causing some real trauma. And in top right there, we can see the tip of the canines is buried in the mucosa there. So uncomfortable. So this little guy had some crown extensions on. So we didn't need to be as extensive as with Poppy. We had the space. We just had to direct and put some force on these canines, some tipping force, and move them out of the way so they came out of contact
Yeah.
with that mucosa.
Yeah, and I guess the image on the lower left shows it's an immediate post-op. So you can see that she can't fully close her mouth at that point. In order to do that, she's going to have to sort of, get those teeth to tip. Danielle asked a question as well, that do they need an anesthetic to remove the extension? Yeah, absolutely. These are really hard to remove. And there's actually a genuine risk of fracturing or damaging the tooth. Because we're using materials that are designed to stay. There's no materials at this point where you can almost reverse the bond to the tooth with anything magical. It's essentially controlled force that you're using to get them off. Yeah.
And as you can see,
we use a straw mold. For this one, we did. For Poppy, we actually found that a IV catheter, I guess the case for an IV catheter cut down was the perfect size. So yeah, we are using objects, I guess, to act as a bit of a mold. So we're injecting the material into that and then curing it onto the teeth.
And back to what Danielle was talking about as well. That's why we use these funky colors, so we can actually tell which is tooth and which is our material. Because when we were using for various other things, using tooth colored material, it was a tough call. So this cat went very well. And unbeknownst to me, one of my new kittens I got at the start of 2020, because I didn't look, she was also had the same situation. So we actually performed that with her not so long ago too, and she went very well. Beck did a great job.
Yeah, so this is a post-op, it's an immediate post-op, and you can see just how much, I guess, clearance of that tissue we've achieved. And she has, I guess, again, a really good positive outcome with that. For her, it was a 4-week treatment, 2 anesthetics to do it. And the big benefit for her is she leaves, goes home and forgets about us, never has to see us again. So, and essentially has a normal functional occlusion, which is honestly a great outcome for her.
Yeah, absolutely. So we talked about with orthodontics, so we need somewhere for teeth to move to. And with Poppy, we were able to actually perform, I guess, that extra set of orthodontic movements at the start of the procedure to create that space. This pup here, what we've done with the 3rd incisors, we're completely stuffing up the whole situation. Remove them. They're out of the way. That's an immediate opening of that diastema. And so now this dog has got somewhere for those teeth to go. This dog, however, didn't have a crown extension or malar.
Nasal chain.
Nasal chain, sorry. What this dog had is an inclined plane. So an inclined plane is an orthodontic device that we create within the animal as they're anesthetized. You can have them created externally, but we create them while the animal is anesthetized. And again, we're looking at creating the same force that's going to force these canines in a more labial position. So this material is applied to the maxilla. We attach it via wires to the canines and to the 3rd incisor, so it stays in there. This is not a removable device. And we create these grooves. This actually more closely approximates what we do with a gingival wedge. But again, because we've put the material in there and we have complete control of all of the shapes in there, we can be more aggressive with the movements, and they're more effective generally because it's also a constant. Versus something like ball therapy, which also tries to do the same thing, but is always intermittent. And I think on the next slide, we've got a few pictures. Well, Danielle's got another quick question there about costs. I can't remember what we did for that cat.
That cat was owned by a nurse, so
that's right.
it didn't get charged as I guess it should have. But to give you a ballpark for the initial procedure, you're looking around sort of the $2,000 to $2,500 mark, and then removal is sort of, you know, up to again that sort of thousand. So $3,000 to $3,500 for your orthodontics. If it's a single stage sort of thing for the incline plane or the extensions, would be a rough ballpark. It is straight up a bit more expensive in total than say extractions or height reduction, but again the benefit is that if it works, they're normal, they don't have follow-up, and they maintain, I guess, structure and function. So again, there's so many factors that go into deciding what the right treatment is for each individual, and it's client factors, it's patient factors, it's finances, it's it's a number of different things we're talking about.
So there's a couple of examples here of some other incline planes. Oh, excuse me, I'm about to cough again.
I'll take over. So this one here is a different sort of, there's lots of different designs or ways you can do them. This one was one we played around with for a while because there's a school of thought that you don't really want to limit expansion of the maxilla. To be honest, I feel like it might be beneficial because part of the problem is that often the maxilla is a bit wide compared to the mandible. So this one actually has a telescope in it. So we use different size needles, and they basically act as I guess a bridge to stabilize the two sides, but act to sort of, you know, it'll telescope open if the maxilla decides to widen during the course of treatment. But essentially they're two independent I guess areas of composite, and we still create the exact same sort of inclines or I guess almost like a ski ramp into the actual composite. And we aim of that essentially the tip of the canine will engage, and every time the patient closes its mouth, it's going to exert a tipping force and will end up with the tip of the tooth essentially traveling up this ramp that we've created in the plate. There you go.
Yeah, and I guess when I did this that slide up, I put them in sort of, well, what I think now is the wrong order. In the middle here, we have this dog at presentation. Diastema is open. Okay, there's a space for this tooth. So this guy's just quite linguiverted, quite vertical. So we've placed on the left, we have the incline plane now is put in. This dog will go home, and much like that we saw with the kitty with the crown extensions, these dogs can't close their mouth completely when they leave. And so through general use over the next 3 to 4 weeks, what's going to happen is for the mouth to close, the teeth need to tip. And in the bottom right here, we can see two things. It's not quite closed, so you can't, it has moved, so we're happy with that. But what we're also seeing, there is a little bit of a problem that we have with these devices. A lot of mucositis occurs underneath them because it's got something stuck on the palate for this whole period. It resolves quite rapidly. Usually within 24, 48 hours, it'll settle right down. Well, actually looking at that picture a little bit more, Beck, I can see in comparison to when it first presented, we've got actually some gingival recession around that third.
Yeah, absolutely.
Yeah. So it's not innocuous. In saying that, it resolves quickly, and there's generally no. Everyone's too busy cheering that the tooth is to be particularly worried about that. So complications of these things, I guess throughout we have mentioned a few of the problems that we do see. Orthodontics, I guess the biggest failure and concern for all of us is we actually may not be able to move them into the position we need to. Hopefully we've been able to, with some experience and knowledge, predict that to a large extent. Although in saying that, I still am surprised sometimes what we can really do. But failure to move. So therefore we would have to then move to a second, a more definitive procedure. Long term, we certainly know it's an issue with human orthodontics. There may be an issue with tooth resorption or root dilaceration more long term. Appliance failure is a complication, certainly. That's part of, I guess, decision making. If you can predict the behavior of an animal, are they going to be compliant?
Are they
Rather than
going to
having,
break the appliance? Are they going to break a tooth in the process of trying to get the appliance out and end up with, a mouthful of broken teeth as well, which are all considerations and things we need to discuss with clients. What's going to happen if they do damage or break it? What financial implications are there as well if we have to go in and repair it and do an extra procedure?
Yeah, I remember we did when I was working with Gary a long time ago. I remember a client came back in with the dog and the plate, but they were separate. And he asked if we could put it back in again. But no, because it's actually missing a bit. So we had to redo that one all again.
Yep.
With high reduction, I think clearly the biggest potential complication is the death of the tooth. And not an insignificant complication. That may require then either extraction of the tooth. That is possible. Often because of the timing, we talk about doing it at 8 months. Some of those dogs have not completed apexification, so they don't have a root tip. If it dies early in the process, we're unable to do something like a root canal because there's no root tip. Yeah, so if it has matured enough but still died, a root canal procedure is possible.
And not horrendously abscessed and resorbed as well.
Exactly. But a complication during the process is loss of restoration. And as much as I said before, I think we rarely see it these days. It does occur. And again, in this early period and throughout life, but certainly in this early period, loss of restoration will lead to complete failure within a short period. So it can be a real problem.
Yeah, for sure. I guess Kara's asked a question and that falls into the complications of extractions. Our most common complication with lower canine extractions is wound breakdown. You've got a patient that's usually young, silly, is going to still use its mouth. And there's, I guess, other complicating factors as well. So they can physically damage the flap that you've created and physically remove or pull stitches. The other things that contribute are in the bigger dogs. We really have very few problems with the smaller breeds, but the bigger breeds, especially those with the big jowls, there's also this tension that's constantly pulling, and there's not really a way of avoiding that. So there is always going to be some downward sort of pulling force from the actual jowls or the lips on those extraction sites. So breakdown is a real thing. It occurs. Again, if you've done a good surgery and you've left the bone in good condition, so you've smoothed any jagged margins, removed any sort of loose fractured elements, and I guess left things in a fairly clean state, if they open and break down, they will heal. That's our biggest thing that we reassure clients. I think in all the years I've been working there, we've gone back in once and debrided and repaired a mandibular canine extraction site. The others have all healed pretty uneventfully. I had a Labrador a few weeks ago, managed to wedge an entire stick down his extraction site. We managed to fish that out while he was awake, and within 3 weeks it was completely healed over. So our approach with those is to actually intervene very minimally. Antibiotics, if it's really indicated, I don't know if it ever really is. Generally, it's a Band-Aid. They will get a bit smelly. It's often just surface debris sitting there, and if you gently flush it away, everything should be fairly clean underneath. We don't encourage the owners to clean them out or do anything at all. In fact, we generally tell them to leave it alone and come back weekly till it's healed. So in analgesia, antibiotics, if you really think it's indicated, or sometimes just to keep everyone happy, unfortunately. Weekly checks and diet. Our big thing is to avoid soft, sticky foods that are going to pack into that site. Dry food's actually fine. I actually think it's probably one of the better things. They're eating that, they're generally swallowing it or chewing it at the back. It leaves very little residue. I find they stay cleaner than even the ones on chunks of meat. So anything that's a fingernail size piece that holds its shape that they've in a vacuum cleaner, that's what we recommend, and continuing to avoid mouth games, anything where they're picking up and shaking with the front of their mouth until things have healed over. And generally speaking, within a few weeks, 2 to 3 weeks, everything's fine. So it's certainly not the end of the world, and it is a reasonably common complication with these particular extractions. And the other thing we spoke about earlier was checking them after extraction and just making sure that the mandibular incisors are then not impacting and starting to traumatize the roof of the mouth.
Yeah, and you did mention it back. You did say weekly checks. So I agree. Intervene minimally, but monitor frequently. And I guess that actually is way more broad than this indication. If we keep in contact and communication with our clients and work them through what they can certainly see as a difficult period, at the other end, they're happy. They understand that we've done everything we can, as much as we actually haven't really done much, and just let the animal do what it needed to do.
It's a reassurance that things are going okay.
Absolutely.
And again, we've also always spoken to them about it in advance as well. So when it happens, it's like, oh, you did say it happens.
Hopefully forewarned.
Oh, well, you also said it'll be okay. So, yeah.
Yeah, I agree. So I think that brings us to the end, doesn't it?
It does, yeah. So if there's anyone got any additional questions, or there's one.
Philip, we recommend both. So our extraction post-op notes include discussion of kibble, and certainly a change away from material that's going to break up. So we really want to avoid what we all think it's the go-to thought for all of us: soft foods or mince, certainly canned foods.
Although that said, I'm less fussed about what people eat. I still enjoy like the soft, mushy, tinned canned things, but the Royal Canin, the chunks in gravy, they're pretty rubbery cubes. That sort of thing. If it's not got the rice and veggies and stuff thrown in with it, I'm okay with that.
I think a bit of we have not a great change, but a little bit of a change we've had in that advice over the last few years has come about through just being more in contact with people through this post-op period. It's not a great deal, but a number of patients would go home and follow this diet change. And it's from a mission from us finding out, really. The diet change that, they will change to meat, well, that actually upset the GIT. So as much as we can, I actually now will, and I should have been, discuss what they eat and then make any adaptations to that. And if they can stay on as close as possible to what they're normal, then we don't see these dogs. He started having diarrhea 2 days later.
Yeah, we try. I guess part of it is that if we're able to, if it's appropriate, use non-steroidals as our primary post-op analgesic. So we really want to minimize the chance of them developing a gastrointestinal upset. Like Aaron said, finding out what a patient's on and figuring out within what they're already exposed to what would be appropriate. So my general advice is anything that's a fingernail size piece of something that holds its shape and doesn't break apart is okay.
So to answer your question, Philip, we do recommend kibble. If they're on kibble, keep going.
Probably not TD.
No, not TD.
Something that's they don't physically have to crunch on, so like a general normal size kibble that's not designed to really that they have to bite down on and chew. That's sort of generally what we recommend. And have not seemingly seen any increased level of breakdown.
No, or wound contamination. We don't. It's just rare. I wanted to say doesn't happen, but we can't say it does. Yeah. Okay. So again, feel free to ask questions. Feel free to send questions. Okay. So I've got some contact details here for both of us here at Advanced Animal Dentistry.
Yeah, I think there'll be generally Bianca sets up a little questionnaire once we finish. I guess we have now concluded our base narrow sort of little series. So we are open to suggestions as to hot topics for the next ones. It will probably either be looking at extraction techniques and looking at going through individual teeth, and potentially also a series on dental X-rays. So obtaining images plus interpretation as well. So there are a couple of ideas we've had, but if there's anything particular that you're itching for, let us know and we'll try to.
Please do. And also in regards to previous webinars that we have done, they are both recorded and they're up on our YouTube channel. A link to that is on the webinars page on our website. I am just realizing that it's not off the front. We don't have a link off the front page, which we might need to change. But at least you've all been through that webinars page on our website when you signed up for it all. So if you head back there, you can go on through and look at previous webinars if you haven't, or show your friends. Yeah.
One more question.
Oh yeah, it is a good topic, Peter. Yeah, absolutely. And yes, Erica, yeah, extractions as well. These are do we struggle? I struggle on extractions sometimes.
Yes.
Not as much as I used to.
My career choice.
Yeah, and X-rays, sometimes they don't do what they're supposed to do. So yeah, they're classic. Yeah, we do need to address them. So we'll knuckle down and get something up for those. On behalf of me and on behalf of Beck, thank you for being participating in this webinar series. It's been good. Yeah, I could listen to myself all night. Yeah, it's been great. So looking forward. Really, Danielle? I'll do the webinar now. Take it out. The question was, how about ginger? No, it's actually a really good topic. I really do think it's a good topic to cover. Yeah, for sure. So hit us up with feedback, guys. Let's do this again.
Yep. Okay. Cool. Have a good night, everyone.
Yeah, thanks, guys.
Right. I'm done. See ya.
You're still recording, I think.